Now let's look at the prothrombin time or PT. This test evaluates the extrinsic system and the common pathway. The PT is particularly important for assessing clotting factor 7 activity, which is the factor with the shortest half-life in this pathway. Normal values fall between 11 and 12 and a half seconds, while critical values are greater than 20 seconds, and they raise major concerns about bleeding risk. PT is used most frequently to monitor warfarin therapy, since warfarin acts by inhibiting vitamin K dependent factors 2, 7, 9, and 10. Now, when interpreting PT, keep in mind that this test is not only for warfarin monitoring, it can also reflect conditions such as liver disease and vitamin K deficiency or hereditary deficiencies in clotting factors 2, 5, 7, or 10. And PT is one of our best tools for understanding the extrinsic pathway, and it often pairs with INR, which we'll discuss shortly, to provide standardized results across labs and counties. Collection of PT is the same as collection for APTT with a blue citrate top or top tube and non-fasting labs. One of the key considerations in PT is that results can be influenced by multiple external factors. For example, alcohol intake or malabsorption syndromes can increase PT, while diets high in fat or leafy greens or leafy veggies, which are rich in vitamin K, can lower it. Medications also play a huge role as some drugs prolong PT while others decrease it. This highlights why taking a thorough medication and dietary history is crucial when interpreting coagulation results. When PT is prolonged, we need to think about both inherited and acquired cases or causes. Liver disease is one of the most common because liver produces many of the clotting factors. Hereditary factor deficiencies, particularly in 2, 5, 7, and 10, can also prolong PT. Vitamin K deficiency, whether from malnutrition, malabsorption, or bile duct obstruction, leads to impaired factor production. And coumarin ingestion, DIC, and massive blood transfusions, even salicylate intoxication, are additional culprits. Each of these contexts should prompt us to integrate the lab value with the patient's broader clinical picture. This is looking at the comparison of heparin and coumarin monitoring or Coumadin monitoring, where we use PT or APTT. And then this is comparing and contrasting our intrinsic and extrinsic pathway and where we would potentially utilize these labs to interpret both. I mentioned the INR, and the INR, the International Normalized Ratio, was developed to standardize PT results between labs. Since PT values can vary depending on the reagent used, INR is calculated by dividing the patient's prothrombin time by the control prothrombin time and then raising it to the power of the International Sensitivity Index. A normal INR value ranges from zero point 0.8 to 1.1, and a critical INR is greater than 5, which significantly increases bleeding risk. The INR is especially important because it allows safe and consistent monitoring of patients worldwide who are on oral anticoagulants like warfarin. So let's walk through the calculation. INR equals the ratio of the patient's PT to the control PT raised to the power of the ISI, or the International Sensitivity Index. An INR of 1 indicates normal clotting time. An INR above 1 indicates prolonged clotting time. For patients on oral anticoagulants, the therapeutic range is 2 to 3, though it may be 2.5 to 4.5 in special circumstances like mechanical heart valves. Understanding this calculation ensures that we appreciate both the clinical application and the reasoning behind the number. This is showing again normal findings and the critical values. Normal findings 0.8 to 1.1, critical values anything above 5. And at this level, patients are high risk for spontaneous bleeding and might require urgent medical management. On the flip side, an INR that is too low on a patient on warfarin means that they're undercoagulated and at risk for clotting. Therefore, monitoring is essential to balance bleeding and clotting risk. Coumadin, aside, also known as warfarin, is a vitamin K antagonist. It inhibits the synthesis of vitamin K dependent clotting factors 2, 7, 9, and 10, as well as proteins C and S. And because factor 7 has the shortest half-life, it's the first to drop when warfarin started, which is why PT and INR are used for monitoring. Warfarin takes several days to reach full effect as circulating clotting factors degrade at different rates. And this is why patients are often bridged with heparin in the acute setting until warfarin becomes therapeutic. When we come back, we will look at bleeding time and its applications.